Right, I think I'm live. Hello, welcome everybody. My name is Dr. Peter Leung. Hopefully you will be able to see me in this internet. We are running a Facebook live session. Oh, good. All right, I can see people starting to drop in. Hi, everybody. Hi. My name is Dr. Peter Leung. Welcome to the evening, the Q&A sessions concerning fertility treatment, miscarriages, and it's a pleasure to talk to all of you. I think we just started off by introducing myself. I'm a fertility specialist working in IVF Australia. My name is Dr. Peter Leung. I have been working as a fertility specialist for over 20 years. My office is around in Sydney, so I'm based in Sydney, obviously. So it's in Greenwich, in Castle Hill, in Haymarket, as well as in Chatswood. And I'm the clinical director in the Fertility Centre, the low-cost IVF Centre in Liverpool as well. So hopefully today, obviously I can share some of my experience with you guys out there. And obviously we'll be more than welcome to talk any topics that is of interest to you guys, right? Today's, just want to get something clear. I'm trying to obviously, if you get questions, feel free to type on the questions and answers sort of page. I get my assistant trying to send the questions to me because sometimes if there was a problem in terms of sending the question through, then I'll try to check it on my phone. So if you see me looking down the phone, it's because I'm actually trying to see what questions has come through so that I can actually address those questions for you. Okay. Now, as a start, I think we just talk a little bit more about the topics that I think is concern for a lot of people. Initially, we want to start with talking about the problems of miscarriage. Miscarriage itself is actually a very common problem. Lots of people doesn't aware of the fact that miscarriage is such a prevalent situation that if you actually talk to your friends or relatives, they have basically have encountered some people actually have it beforehand. If you look at the general incidence, we talk about 15% of the pregnancy or recognized pregnancy maybe end up in having a pregnancy loss. Now, this percentage obviously would be higher if you actually define the pregnancy much earlier. Like, for example, you take the positive pregnancy test as a means of confirming a pregnancy, then the chance of very early pregnancy loss can happen a lot more often than not, because some of the patients even don't recognize that they actually have a pregnancy loss if they have just a late period and haven't bothered to check the pregnancy test. So sometimes that could happen as well. For the clinically recognizable pregnancy, that means the one that we already have done an ultrasound scan to check that there was a gestational sac within the womb itself, then the chance of pregnancy loss is a bit lower, and that's usually going to be between like 15 or 20% usually. Now, that's the risk of the pregnancy loss is obviously related to the maternal age. So we do see that the chance of pregnancy loss in relation to the quality of the eggs as the women get older altered. And this is also tied on to the similar stories of advanced maternal age patients having risk of Down syndrome, so having risk of miscarriages because their eggs number as well as the quality of the eggs get altered as they're getting older. So that remains one of the most common causes of people having miscarriages is because of those genetic issues. So roughly, speaking, in looking at the etiology of why people are actually having a pregnancy loss, we understand that at least about half of them is related to genetic issues and related to the pregnancy. So the first thing I always talk to my patient is that if you unfortunately encounter the pregnancy loss, most of the time it's not related to you or your partner. Most of the time it's actually because the pregnancy itself has a problem. And so they are unable to continue to basically implant or grow further. And so naturally, then the baby would stop growing, and so the body would recognize it and then manifest itself as a pregnancy loss. There are obviously other suggested causes of miscarriages, and those causes in general is less common. But it may be started to become more common if you have a condition called recurrent pregnancy loss or repeated miscarriages. Now, the definition of those does varies a little bit depending on the locality that you're working on. If you take the UK condition, then they usually recognize 3 pregnancy loss as a repeated miscarriages loss, as a recurrent miscarriage. While if you actually go into European country, they would maybe only using two consecutive pregnancy loss as a means of diagnosing repeated pregnancy loss. So the definition is slightly different, but if you look at the chance of finding abnormality in those conditions, they're fairly similar. And so overall, it is reasonable for people wanting to do further testing, after you have two or more pregnancy loss, to find out whether there's an additional contributing factor. Now, the test that commonly run by the doctors usually is in terms of finding genetically whether there was any problems with both parents, including the mums and the dads, basically. The risk of finding abnormality is usually on around between 5 to 6%. So it's not a huge chance that you would have genetic issues. But if it does happen, then it is important to rule that out, mainly because the pregnancy issue, if you do have a genetic problem, then this is important because it can pass on to future generations. So from that perspective, it is important to recognize that. Now, I've just got questions about, people asking about progesterone pessary, reducing miscarriages. Now, this is a very controversial issue that related to what the reason why the miscarriages is happening. Now, if you believe that the majority of the cases is really a genetic issue, that means that the baby itself has chromosome defects, or they are genetically not compatible with of cell division or having problems of organ formation, then unfortunately the progesterone pessary is not going to change that, because that's going to be fixed by the time that the eggs and sperm are joined together. That already created the pregnancy from that onwards. There's a small proportion of patients having some sort of problems in accepting the pregnancy to continue, such as there was immunological problems, or there were hemophilia problems, or what we call the luteal phase defect, where the corpus luteum function that is unable to produce enough hormone to sustain the pregnancy. Now, so in those conditions, then yes, we would think that giving progesterone sometimes may help in those conditions, but it remains very controversial because we're still waiting for a large-scale randomized trial to confirm that. And there are currently some studies actually running in the UK as we speak to try to address exactly that condition. Okay, but yes, okay, so that's why we don't routinely ask people to be on the progesterone pessary, but rather actually ask people to ask their fertility doctors or their GPs for opinion, and if they find out there was a problem, then they usually would try to suggest people whether they should or should not be on the progesterone. Okay, now we're talking about the next questions about why do some embryos with Down syndrome miscarry and some survive? The majority survive or miscarry. It's a very good question. Now, the Down syndrome is actually one of the lesser problems in terms of genetic aberration of chromosome numbers, and that's why some of the embryo with Down syndrome actually could survive and be compatible with extrauterine existence. Some of the other chromosome errors, such as chromosome 13 errors or chromosome 18 errors, they're usually incompatible with life, okay? Because the chromosome that they are having trouble is entailing a lot of important and critical genes that is essential for survival. So unfortunately for those conditions, then if you have those chromosome errors, then they are not compatible with life. While the trisomy 21, which is what we call the Down syndrome, then those are the conditions that's actually more compatible with life, and so some of these will be able to be seen as a newborn. And so hopefully that would address some of the concern, okay? Now, next question is, why do people have repeated chemical pregnancy? Is low progesterone level one of those causes? Okay. Now, nobody knows why people actually have repeated pregnancy loss. As I said, we have tried to run a lot of tests on some of these couples where they have had multiple pregnancy loss beforehand. We can only find problems only about in half of them, and half of them actually we don't know exactly why. And it usually manifests itself, as I said, in early bleeding. And some of them, if they monitor the pregnancy, they would find out there was a low progesterone or low pregnancy hormone, low HCG level. Now, it's a bit of asking whether it's actually the chicken or the egg coming first, okay? Most of us would believe that the low progesterone level or low HCG level is just a manifestation of a sick pregnancy, where the pregnancy itself has a problem, and so it wouldn't be able to cope by showing that they would increasing secretion of the hormone to maintain itself. And so if you monitor for those hormones, then it would be more than likely to be on the lower side, and so this may not be the cause itself. It may be just a consequence of an abnormal pregnancy. So it is traditional for us to look at it that way, rather than attributing these as the original cause of the pregnancy loss. Okay. All right. So I've got another questions talking about a little bit the different things. Okay. They're asking about they have a day 7 embryo in the freezer probably, okay, but the embryo hasn't been tested, but just wondering thoughts on transferring positive outcome. Is it worth transferring? Okay, now this is actually a very interesting question. Okay, now normally just to address some of the background information about the freezing thing. Now this is talking about a couple having IVF treatment where they already generate some embryos. So normally we have fresh embryo that we put back inside the womb, and then additional surplus embryo we've done to try to put them in the freezer, which is we store them in the liquid nitrogen, which then you can last for ages, on end, and then allow the doctors to do the transfer in the subsequent time. If the fresh embryo wasn't successful, or if they are very lucky they already get the first baby and they want to have their second baby or third baby, then you can use those frozen embryo that we cryopreserved years ago or months ago, and then putting back inside the womb. Hopefully it would work again. All right. Now, normally we would like to try to freeze the embryo in a certain stage, what we call the blastocyst stage, which is about day 5 of embryo. And however, some of the patients, because of their rate of development is a bit lower or slower, and so some of the scientists would try to freeze them in about day 6 or day 7 because they want to give them a bit more chance for them to grow. So overall, we do see pregnancy quite consistently in terms of level between day 5 and the day 6 embryo that put in the freezer. Now, for day 7 embryo, that means that you give them an additional day to grow and then put in the freezer. We do see some pregnancy out of it, but the pregnancy chance is a bit lower when comparing to a day 5 and day 6 beautiful embryo because they do mean that their rate of metabolism or their chance of successful implantation may be a bit jeopardized because they're exhibiting a bit of slower growth. But nevertheless, they are still good embryos to put in the freezer, and if they survive, then it is still worthwhile to give it a try because we do see, some pregnancy generated out of those embryos. So don't discount those, and we are still recommending people to try on that. Okay. Now, next question, right? And so they're saying, okay, is in all IVF cycle has a 90% fertilization rate. This time, down to 50%. What could have happened? There's no change in diet. We use a trigger and half this time instead of one trigger, right? So the issue is that we had the fertilization. That means that we're talking about eggs and sperm, so joining them together. Now, traditionally, we see this as a normal range between 80 to 90%. That's actually the normal expected range. No, because nothing is perfect in biology. If you get 10 eggs, you put the sperm together into the eggs, then we expect that about 80 to 90% of them will be able to do their job properly. However, if the pregnancy, the fertilization rate, that means the eggs is being able to join with the sperm has dropped to about 50%. That would be a little bit lower than what I would expect it. Now, that would have a lot of possible reasons. We don't sometimes be able to identify exactly what is going on. Remember, the fertilization needs contribution both by the eggs and the sperm. Although obviously it could vary because of the egg quality and the sperm quality on the day that we do the egg collection, as well as possible changes in terms of the laboratory environment or the medication that you use. Now, all of this could contribute to the chance of having a lower fertilization rate than normal. Okay, but having said that, without knowing the details, I can't really give you a concrete answers to those questions. But it would be a good idea maybe to review this with your fertility specialist so that they can actually go through your whole treatment cycle and understand a bit more about what are the additional risk factors that can lead to this issue. Now, don't panic though. There are methods that we can actually try to correct fertilization problem. In particular, there's a procedure what we call ICSI, an intracytosis sperm injection. What it literally means is actually sometimes we can ask the scientists, instead of asking them to add about 10,000 sperm surrounding the eggs and do a natural selection within the petri dish, we can actually ask them to artificially select the sperm by looking at the morphological parameters of sperm, such as the fastest swimming one or the most normal looking one, and then ask the scientists to pick up that particular sperm they're happy with and inject it directly into the eggs. And in that way, hopefully, most of the time we can restore the fertilization rate to a much more normal level, up to usually about 80-90% sort of parameters. And if those things still doesn't actually correct the problem, then in IVF Australia, in the organization we're working at, we do have a better technology, what we call the high magnification sperm selection, in the sense that the scientists have now been able to look at the sperm in real time in a very high magnification microscope. We're talking about up to about 3,000 or 4,000 times of magnification, and then basically based on that they can use that microscope to select sperm in a much more succinct way than the old type of selection, just magnified up to about 200 times under the standard microscope. So looking at the ultrastructure, in particular the head shape as well as when the head defect there, then sometimes these could help, in selecting a better sperm and allow the fertilization rate to go better in a sense. So that those things hopefully will be able to address some of the problems that this particular patient had. All right. The next question we have, it's completely different topics. It's talk about endometriosis, right? So they talk about whether this endometriosis itself would increase the miscarriages rate. Okay. Now at the moment we don't know for sure. There has been some suggestions that endometriosis can contribute to difficulty in having successful IVF outcome, be it because of the endometriosis itself is jeopardizing the ovarian function, because endometriosis is a condition of the lining of the womb growing outside the uterus, basically. So commonly a deposit will be in the back of the uterus, around in the ovary, and that sometimes can affect the organ function in a sense and causing trouble in falling pregnant, as well as affecting the ovarian activity, or sometimes damaging the ovary itself, causing reducing in ovarian reserve, as well as trouble in having a natural conception. Now, in doing IVF, we are supposed to bypass some of these issues because we are getting the eggs and sperm outside the body, creating the embryo, and then putting back inside through the bottom end, in a sense. However, the endometriosis itself, there's been also a theory that it can disturb the immunological function within the system. And these ectopic endometrium in the peritoneal cavity, sometimes they can secrete lots of inflammatory mediators and cytokines, which is kind of like a hormone signal within the body, that if they have an aberrant sort of signal, it can affect the chance of implantation. So there are some discussions about this that could be happening. And so if you do have a recurrent pregnancy loss, or you have a recurrent IVF failure, then some of the doctors, in particular fertility specialists, may discuss with you the options of checking the condition of endometriosis. And so those, however, need to be discussed in detail with your doctors, because looking at endometriosis may not be easy to pick up. Some of these minor changes of endometriosis can only be detected through operation, what we call the laparoscopy, where the patients need to have undergoing general anesthesia, and then they would need to put in the stethoscope through the belly button, and then have a direct inspection in the pelvis to find out what's going on. And then if there was identified with endometriosis, then the doctors may try to treat them surgically in the hope that it would improve the chance of a natural conception, or aid in the process of doing IVF, reducing the chance of pregnancy loss, that sort of thing. Okay. All right. Next questions, right? Now, doctor, I have 4 natural pregnancy, no known fertility issues, but I had tubes cut about 10 years ago, right? Okay. And then after 5 ancestral transfer, I'm having the 6th, transfer this week. Is there anything you can recommend taking to help to implantation? This is my last frozen. I thought saying after transfer and Oripro, which is a progesterone, 2 days prior. I've read aspirin might also help. Is there anything you can recommend? All right. Now, I know people obviously would be quite upset if they have multiple tried of IVF is still not having a successful outcome. I don't know, obviously, this particular patient's detail. Normally, if you had multiple transfer of embryo and still doesn't have a successful implantation, then, as I said, some of the doctors would try to look at other correctable factors that can explain the situation, including checking your immunological systems and checking the anatomical issue. That means that sometimes we have to do what we call a hysteroscopy examination to look at the uterine cavity itself. as well as natural killer cells, or as well as the thrombophilia factors, as well as a genetic issue. So those are the things that usually the fertility specialists would actually recommend to do and actually exclude, so as to look at the potential correctable causes to improve the chance of implantation, right? Now, in this particular circumstances, it looks like the doctors already have had some sort of workup, because this particular patient is actually talking about they're using medication such as the blood thinning medication called Clexane, as well as the progesterone tesserae, which sometimes can have immunomodulation effect. Now, without further knowing exactly what test has gone through and whether there's any positive outcome, I can't really comment on whether these add-on treatment has had any values. Some of these medication we're talking about is actually quite controversial. In particular, using these aspirin therapy that they are mentioned about has not been universally accepted as value in unexplained recurrent pregnancy loss or unexplained infertility in such an extent. It might have some positive outcome if you do have proven to have some immunological problems, and so your specialist would then be talk to you about the controversy surrounding the use of these medication, as well as whether it is advisable to use them. So the next question we had is talking about ectopic pregnancy, right? So they're talking about having ectopic pregnancy about 7 years ago, and whether they can think about using insemination or IVF treatment. And in particular, this patient mentioned they're already at 39 years of age, right? Now, personally, I would think that in your circumstances, perhaps IVF would be a better choices in general, okay? Why are we saying so? It's because usually ectopic pregnancy, most of the time, is actually landed on the fallopian tube, okay? That's one of the common source of the ectopic pregnancy. While the treatment of ectopic pregnancy has been completed, they are usually quite commonly having some damage to the existing fallopian tube. And also there is a suggestion that if you are prone to develop ectopic pregnancy, that may also indicate the other fallopian tube that has not been involved in the last ectopic pregnancy may also have had problems. And so from that perspective, the chance of having tubal causes of infertility is a bit higher in this particular patient. Now, insemination treatment is a treatment that we use for patients usually having borderline male factor infertility. That means the sperm may not having sufficient numbers or sufficient activity, or they're having trouble of time intercourse, or the ovulation may not come through. However, it does rely on the normal functioning fallopian tube to work properly. If you can imagine that the insemination treatment by working in controlling the timing of the ovulation, as well as getting the washed sperm to put it inside the womb, the sperm still have to do its job by swimming up all the way into the fallopian tube, and then finding the eggs, and then getting the fertilization happening in the fallopian tube, while the good fallopian tube would then be able to transport that fertilized eggs into the womb to allow implantation to happen. And if you can imagine, if the fallopian tube has had some sort of disease or having troubles, then this function may become compromised. And so obviously it may not be having as high a success rate as we hope to see. So from that perspective, I think IVF probably is a better choice. And on top of it, we also have data to show that if you are close to the age of 40, the chance of success using insemination also tend to drop, because in doing the insemination, we are using usually only 1 or 2 eggs and trying to create the pregnancy that way, using a very low dose stimulation, low dose medication. Now, that may not be working very well if you are of 48 or age 40 or above, simply because the egg quality, as we talk about, get changes, and so the chance of you within having a good quality eggs within that 1 or 2 eggs that we're trying to get from giving you the medication may not be as high as a conventional IVF, where we usually stimulate the ovaries to collect at least about 8 to 10 eggs, and so the chance of you finding a good quality embryo that have all the right genetic complement to start on getting a viable pregnancy will be higher that way. So most of the fertility specialists will start to mention these sort of differences if the patient is approaching age 40, and so they may recommend, I think, IVF more than insemination in those circumstances. Right. Okay, right. Now we get other questions asking about adding LH in combination with FSH in the IVF treatment. Does it help in the success rate if they have recurrent pregnancy loss? And they have a very low level of LH and on the day of trigger, but prior to this was above 1. how are the success rate for a frozen egg transfer? Now, they're talking about adding additional adjuvant hormone therapy in a standard IVF treatment cycle. Now, the standard IVF treatment for patients is usually involving an FSH injection. That means a hormone to stimulate the ovaries to produce eggs. And then we need to put in one hormone to prevent premature ovulation happening. That's usually in the form of a GnRH agonist or a GnRH antagonist. That's either a nasal spray or injection, so that you can make sure that the eggs can be harvested and collected in the right time without worrying that the eggs is going to ovulate in the middle of the cycle. Now, some people obviously try to add on additional hormones in the hope this would get a better outcome. Now, those hormones we're talking about it can be a variety of hormone people have tried. One of the more commonly used adjuvant hormone is called neutralizing hormone, LH hormone, because the pituitary gland, which is in the brain, commonly secretes two hormones to control ovulation. The FSH is supposed to be the one that drives the ovarian follicle developing, while the LH hormone is trying to ameliorate or trying to address the hormone side of things, basically. So if you have a very low LH level, then some people would worry that the ovarian function may not be adequate to give you good eggs, right? However, that remains a very, very controversial point as well, because unfortunately, all these supplement hormone has not been shown to make huge changes in a general population in terms of improving the chance of pregnancy. In particular, if you're talking about the chance of recurrent pregnancy loss, which is a different ball game altogether, because pregnancy loss we're talking about already had a successful implantation. The eggs is actually working. The sperm is already working. It created an embryo and then put it inside the womb. It's already implanted. Okay. Now we definitely don't have any data to say that giving egg supplementation during early part of the IVF cycle is going to make a huge difference in terms of pregnancy loss outcome. It might be beneficial for some particular small group of patients that have deficient hormone secretion within the pituitary gland itself, but that remains a very small minority of patients, what we call the hypogonadotrophic hypogonadism patients, which from the history that's been sending through is unlikely to be the case, because these patients mentioned that they previously had checked their hormone is fine and the previous IVF cycle seems to be okay. So that means that the LH is not essential in their system in doing that. So the other question, part of the question is talking about the frozen egg transfer. Okay, now frozen egg is a different thing. Okay, now frozen egg is talking about where you don't have sperm usually, or you on the day of egg collection we're unable to find sperm. Okay, and so or you want to do fertility preservation. That means that the patients have had trouble in having future chance of achieving a pregnancy because they're currently undergoing significant treatment such as chemotherapy or radiotherapy or cancer treatment that may affecting the chance of having a pregnancy in the future. So that's why sometimes people think about how to help these particular group of patients by freezing some of the eggs, so as to help them to realize the dreams in case that they are running into trouble, they're running out of eggs, then we still get some eggs in the freezer to help them to create the family that way. Okay. Now it used to be very experimental. That means that you talk about the doctors about 15 or 20 years ago. We always think that this may be experimental sort of thing to suggest to the patient, because at that time the freezing technology hasn't been evolved as much as we hope to see. Now the things has changed drastically over the past 5 or 10 years, because we now have a really robust technology to freeze tissue and as well as the freezing egg itself, right? So the procedure of what we're talking about is called vitrification, which is a rapid freezing technology. So now we see that it's a reality. It's now become a routine practice that if patients do need that kind of fertility preservation service, we can offer them to freeze the eggs, and then basically hopefully then it would generate a successful pregnancy afterwards. Now when comparing the egg itself with an embryo, obviously the embryo is already gelled, the eggs are gelled to the sperm already, and we develop them for about 5 days before we put them in the freezer. So obviously they are more advanced stage embryo and they are more robust tissue. Okay, and so the success rate in terms of generating a pregnancy is obviously high with the embryo when comparing to the egg. Usually we we thought that we roughly get about 3% to 5% chance of developing into a live babies for each eggs we had in the freezer. While the chance of achieving a successful pregnancy using the embryo, which usually would be much higher, we're talking about in the vicinity close about up to 40 to 50% if you are young patients having beautiful looking embryos, basically. All right. So that's why you can see that it's actually quite a lot of difference. And so if you need to freeze eggs for fertility preservation, most of the time the fertility specialists will suggest you to freeze enough eggs to give you a realistic chance of keeping that percentage high for allowing a pregnancy to happen in the future. All right. Now, okay, the next question is that they're talking about a patient having anorexia as a teen and never had any periods as was treated before that. And then she's now 38, husband is about 46, and husband has a vasectomy reversal. All the tests come back to be fine. We're looking at IVF next year. Could my past illness affected our chances? Do you recommend embryo glue? What is embryo glue? Now, the anorexia itself may, if it's where you're very young and then everything has now come back to normal and you're able to maintain a normal body mass index, then it probably would not be having significant impact in terms of chance of pregnancy, provided that obviously you look after your health in the past few years and then you are maintaining an appropriate lifestyle, you're eating normally, you are also maintaining a healthy body mass index, basically, right? Now, from the looks of it, obviously they also have other issue because the husband had been on the age of 46 as well as a vasectomy done before. Even if you have a vasectomy reversal, that means the sperm has been able to pass through. Because of the past injury to the vas, sometimes it does affect the sperm's function, despite the canalization has been successful. And occasionally, the husband may also develop the sperm antibody. That means the body has started to recognize the sperm as a foreign thing and then trying to attack them. And so despite you done the reversal, the chance of a natural pregnancy may not be very good. And so yes, you're quite right that some of the couple in that sort of circumstances may need to think about doing IVF treatment sooner rather than later. In particular, you are close to the age of 38, times may not be on your side. Given the past history as well as the husband's situation, I think it's reasonable to address that by doing IVF treatment. Okay. All right. The next question then is talk about embryo glue, right? Now, fantastic, how wonderful the name of embryo glue, right? Okay. Why do you want to add glue to things? Okay. Now, the embryo glue is actually just a commercial product where the laboratory scientists use to add onto the embryo in the hope that this will improve the implantation rate. That means the embryo is sticking to the lining of the womb. Okay. Now, the embryo glue, although it's called the glue, itself is actually not the glue. It's actually an enzyme. It's called hyaluronic acid. Now, the theory goes that, basically when the embryo is going into the womb itself, they need to talk to the lining of the womb to say that, hey, I'm around, and let me in so that I can start to establish the implantation and getting the pregnancy working, right? Now, sometimes we worry that the crosstalk, the signaling between the embryo as well as the lining is in trouble. And so the lining itself cannot recognize the embryo is coming through. Now, the signaling is usually mediated through these enzymes. And if you have a deficiency of these enzymes, then it may be one of the reasons why some people have difficulty in having a successful implantation. So that's why there are suggestions that if you do have a recurrent implantation failure, that means that you have transferred to the womb a number of good quality embryos, and you're still unable to establish a pregnancy, then there might be some suggestions of adding this embryo glue as an additional enzyme may help between the crosstalk between the embryo as well as the lining of the womb. So there are some data to suggest that this may improve the situation in this specific group of patients, but it may not be universally applied to all the other patients. So the answer to that is that we might recommend embryo glue to a certain specific group of patients. And if you need to consider those, then you feel free to talk to your fertility specialist so that they can specifically look at your circumstances and recommend whether it's actually something that would benefit your circumstances. All right, okay. The next question, oh, very good questions, all right. What we mean by regular intercourse? Because sometimes, when you see fertility doctors, they come and see Peter, for example, right, me, and, you're not trying for a long time, you're relatively young. We might actually run a few tests for you and making sure that you're okay, but then ask you to go and try it naturally, right, for a little bit longer time before you venture into the big wild world of doing fertility treatment, right? Okay. So traditionally, we recommend people to do it, at home around the time of ovulation. Now, usually, assuming you get a 28 days menstrual cycle, the ovulation can vary between around hover around day 14, which is in the middle of the cycle, right? So usually we suggest people to start having a natural intercourse from day 10 to day 12 of their period, and then do it at least an alternative day until close to about day 18, day 20 of the period. So why are we doing that recommendation of so-called regular intercourse after every 2 days or 3 days, right? It actually goes with the theory that the sperm can survive in the female system for about 2 days or 3 days, right? So the idea is actually whenever the ovulations happened, the X has always been able to find some sperm around, okay, right? So irrespective whether you ovulate early or ovulate late, and if you cover for those times by doing intercourse every 2 days or 3 days, then there should be always some viable sperm around to allow fertilization to happen. Because the natural fertilization only happens in the first 24 to 48 hours and after ovulations happened. If they don't see the sperm, then basically their egg is gone, and so that month unfortunately will not have any chance of achieving a pregnancy. However, if you do want to do it more regularly, some couple want to do it every day, then that's fine, okay? It's not going to jeopardize your chance by doing more frequently than every 2 or 3 days, okay? Your sperm count or sperm motility may drop a little bit, by doing as frequently as daily intercourse, but you would definitely be able to achieve a similar chance of success, when compared to every 2 days or 3 days, right? But that's why the recommendation is usually at least about 2 or 3 days, because doing it every day might be a bit more difficult for couples to time that. Okay. All right. Next question, right? Is that the husband is having inguinal hernia, but is not reaching to the scrotum, okay? His semen analysis is normal too. Does the inguinal hernia affect fertility? My ovulation is normal too. Now, normally, if your semen analysis is completely normal, then the inguinal hernia is not affecting fertility. The only worry sometimes, people having inguinal hernia is actually associated with undescended testes. That means the testicle is actually not in the scrotum itself, but in the inguinal canal or inside the tummy, intra-abdominally. Now, we want the testicle to be in the scrotum. It's because the design of the scrotum is to harbor the testicle itself, and it would actually protect the sperm production function of the testicle there. Remember, there's a bit of a temperature differences between the scrotum temperature as well as the intra-abdominal temperature. And if the testicle hasn't actually reached the scrotum in appropriate time, it would affecting the spermatogenesis, as well as sometimes increasing the risk of having tumor formation in the testicle itself as well. So sometimes if you heard about kids when they have undescended testes, may or may not be associated with inguinal hernia if it was detected around that time, then sometimes the urologist or pediatrician doctors will suggest them to do surgical correction to bring down the testicle into the scrotum. Firstly is to make sure that they can grow the testicle in a normal environment, preventing cancer formation as well as protecting their sperm function in the future. But if the semen analysis is completely normal, then normally it should not be a reason to attribute to the inguinal hernia. Okay. Right, next question, all right? She's a 34-year-old. She has a low AMH level of 5 and had trouble getting eggs, and the 3 and 4 I get is usually poor quality because they have high fragmentation or not fertilized. Would another laparoscopy clean up endometriosis help, or would it further reduce ovarian reserve? Now, it is a difficult scenario in a sense, okay? She already have existing low AMH, means the ovarian reserve is already on the low side, so that's compatible with the story that she have gone through the IVF treatment and only harvest only a few eggs instead of the traditional 8 to 12 eggs that we hope to see. Now, the difficulty is actually doing surgical treatment on the endometriosis, presuming that's the reason why she had low AMH and as well as the damaged ovary, would help in these sort of circumstances. Because unfortunately, we don't have data to say that by doing further surgery is going to help in improving the ovarian reserve. And in fact, you are quite right that there is some worry that if you do repeated surgery, that you remove the tissue of the endometriosis. Sometimes you remove part of the normal ovary as well. Or while doing the procedure itself, you need to stop the bleeding, and you need to use a surgical instrument to stop the blood loss within the ovarian tissue, and that sometimes could actually damage the ovarian tissue at the same time. So we do have data to suggest that if you have really difficult endometriosis surgery, sometimes you can reduce the ovarian reserve further. So my personal thinking is actually perhaps unless the patient have symptoms like you have bad endometriosis causing you lots of pains or discomfort, or the doctors really think that the endometriosis to such an extent that would affect the other organ function, affecting bowel function or bladder function, or is in the way that preventing us to access the ovary to collect the eggs, then in those circumstances we are forced to think about doing surgical treatment for you again. Short of that, I don't think surgery treatment can help in these circumstances. We may as well actually focus on, basically correcting the underlying pathology by, or even doing further course of IVF treatment to increase the chance of pregnancy. Okay. All right. Next question says, should I wait for 6 months to get pregnant naturally before I go for IVF? I'm 39 and husband 43. Now, the issue is obviously age is very, very important in terms of the chance of achieving a pregnancy. Now, in the close to the age of 39, unfortunately, the time is running out in those circumstances. So, if you already had trouble and you try for a few months and you haven't had a successful outcome, I would strongly suggest you to talk to the fertility doctor, earlier rather than later, and thinking about doing fertility treatment, earlier rather than leaving it in 6 months, before you do that. Because the difficulty is actually the chance of pregnancy changes with the maternal age. With the age of about 39, we're already running a pregnancy chance of per IVF cycle much lower than a younger individual. Say if you're less than 35 years of age, each IVF cycle probably gives you about 50 to 60% chance of achieving a pregnancy. If you're close to 40, then the chance of pregnancy per cycle is only dropped to about 10% to 15%. That's the ballpark figure. So that's why every month from then onwards is actually important for you. So from that perspective, I would recommend you to think about doing the fertility treatment a bit earlier rather than later, simply because that your age and circumstances will put you in the more difficult group achieving a pregnancy, and you might need all the time to allow you to go through all the fertility treatment to allow a more realistic chance that you will achieve that goal. Okay, next question. The patient is actually going through the IVF treatment using a Cinderella long down-regulation protocol. Does it increase equality and quantity? This will be my 6th IVF cycle. This is the first time using Cinderella. Okay. Now, the Cinderella medication has been, we have been using it for many, many years, right? It's in fact one of the breakthrough treatment that we developed in about 20 or 30 years ago when sort of IVF is first introduced. We don't have Cinderella, and then we start to have the Cinderella, and then later on develop a new protocol, what we call the antagonist protocol, right? So Cinderella is not a new medication that we have tried. Now, most people nowadays would use the newer medication instead of Cinderella, simply because it's actually easier to use the short protocol as well as having less side effects. And we also think that it's actually a bit safer for patients to go through using the short protocol in case that we need to use a special medication to change the trigger to prevent hyperstimulation reaction happening. However, in some patients, using traditional, the new antagonist protocol doesn't give them a successful outcome, and they have had many goals of IVF treatment, and they are not at risk of developing hyperstimulation reaction because of their age or because of their previous IVF response, where they only get a few weeks around. Then, in those circumstances, yes, we would think that trying the Cinderella protocol probably would be worthwhile, but it may not be able to alter the egg quality or the egg outcome because it's a random event. How many eggs you'll be able to get, as well as what are the quantity or the quality of the eggs that you get. So at the moment, I don't have sufficient data to look at your previous IVF cycle to put in the comment to see that whether the Cinderella is going to be making a difference. Most of the time, we use Cinderella is just to make sure that you are responding at least, appropriately to give us enough eggs for us to try on the IVF treatment without worrying too much about hyperstimulation response. Okay. Now, next question. Could low fertilization with traditional IVF be a result of the eggs having a hard shell and doesn't um, let the egg in. Now, we thought that the low fertilization rate obviously could contribute from the eggs itself. Yes, you're quite right that if you have a more advanced age or the egg quality wasn't normal, then sometimes you can manifest itself as a failed fertilization, right? But traditionally, we're more worried about the sperm function. In terms of fertilization, right? Because the sperm actually need to do a lot of hard work to deliver the payload, like the genetic code, into the egg itself. And so, traditionally, failed fertilization, we more consider about the sperm function rather than the egg function itself, in the sense that if you have a very poor sperm preparation with a very few numbers of the sperm around, or the sperm doesn't know how to swim, or doesn't actually, go into the egg itself properly, so those are the parameters we look at that could explain the failed fertilization rate. Okay, next question, right? I have a uterine fibroid in the outside of the uterus with a large fibroid obscuring the left ovary. I've been told that the location of the fibroid shouldn't affect my fertility, but it seems the large fibroid does affect the doctor's ability to access the ovary for the egg retrieval. I'm hesitant to touch the fibroid. Is there any reason they can't do the egg retrieval laparoscopically since I'm given a GA? What thickness should your endometrium be? Okay, right. Now, the questions is about the uterine fibroid. Fibroid is actually a very common tumor within the uterus itself. Most of the fibroid is actually, if it's grow outside the uterine cavity, that usually doesn't affect the fertility most of the time, right? Now, for this particular patient, however, the fibroid is growing in a way that is hindering the doctor's ability to access the ovary. Now, remember when doing the egg collection, doing IVF treatment, we usually use an ultrasound scan in the vagina, and then using a small needle where we look at through the bottom end and go through the top of part of the vagina into the ovary, and then collect the eggs out. Okay. Now, if you get a big fibroid on the way in between those structure, then obviously it can push the ovary all the way up and becoming very difficult to access those, right? Now, you are quite right in the sense it suggests that sometimes we can do it laparoscopically. We can do putting a telescope inside the tummy to try to collect eggs that way. That's the old way of collecting eggs, right? However, there are few problems on that. Okay, first of all is that the procedure will become more complicated because you do need a lot more surgical instruments, as well as much more high risk because instead of putting a needle, just a straightforward needle in the vagina, we need to put in other medical instruments inside the tummy, including a telescope as well as one or two more pots inside the tummy. And sometimes the ovary is maybe also still difficult to access despite using the laparoscopy. And the anesthetic procedure would be much more prolonged, and you need a formal general anesthesia instead of light sedation, right? So that means that all these accumulate into more difficult problems. And if you are not successful in the first IVF go, and whenever you need to do a second or third one, then every time you need to do a laparoscopy. So these risks then would accumulate and add on to the patient as well. So that's why I think the doctors there has actually suggested them to think about removing the fibroid, which is a reasonable approach as well. Now, obviously, there are good points and bad points about doing this, and there are various means of achieving this as well. But most of the time, surgical treatment of fibroid is still considered a safe procedure. And if the fertility doctors actually have a experience in removing the fibroid, then you should you should discuss with the fertility doctors to explore that means, where it would be able to allow you to try to improve the easiness of doing a subsequent IVF treatment. Okay. Right. Next question is about the thickness of the endometrium when you're trying to put the embryo in. Okay. Now, normally we like to see the endometrial thickness at least about 7 to 8 millimeter. Okay. It's not the thicker the better, right? The data has shown that if you have a very thin endometrium, that means less than 7 millimeter, then the chance of implantation may be reduced. Now, it's not zero. That means that you still get a chance of achieving a pregnancy, but then it may not be easier to do a transfer, if you have a thin endometrium. So that's why traditionally when you're doing an IVF cycles, the clinic usually would measure the lining thickness for you as well, just to make sure that you have adequate thickness before we put in the embryo. Okay, so the doctors usually would be able to answer those questions for you. All right. Now, I think I'm actually running a bit over time, so I hope that I have addressed most of your questions. Thank you for sending me wonderful questions. These are the common questions we get asked all the time. We're more than happy to put in our thoughts how we, deal with these problems. Now, if you have further questions or you want to discuss further, you can feel free to talk to the IVF Australia team. And we have a 1-800 numbers that you can ring. The number is 1-800-111-483. I repeat, it's 1-800-111-483. You can feel free to ring this number, then one of our staff will be able to, put in contact with you. And if necessary, then feel free to, organize a formal consultation time. Then we can try to specifically address your personal circumstances and discuss, what is best for your situation. Okay, and hopefully I would wrap up in here, and I wish you all the best, and have a lovely evening. Okay, I'll speak to you then. Bye-bye.